Hello guys, you're welcome to our show's Medworld. Today we'll be doing histopathology and we'll be talking about the pathology of infarction. An infarct is an area of ischemic necrosis caused by occlusion of either the arterial supply or the venous drainage in a particular tissue. Tissue infarction is a common and extremely important cause of clinical illness. About 99% follows arterial thrombosis or embolism. Others follows vasospasm, hemorrhage into a plaque, extrinsic vessel compression, torsion, vascular rupture, or vascular compromise by edema or entrapment. Although venous thrombosis can cause infarction, the more common outcome is just congestion. In this setting, a bypass channel rapidly opens and permits vascular outflow, which then improves arterial inflow. Infarct caused by venous thrombosis are thought more likely in organs with single efferent veins, e.g., testes and ovary. What this statement is saying is infarction commonly occurs in it occurs when there's venous thrombosis, and it's more likely to occur in organs where there has a single efferent vessel. An example of such organs are the testes and the ovaries. Now, types of infarct. Based on color, we have red infarct and we have white infarct. Red infarct, also known as hemorrhagic infarct. White infarct, also known as anemic infarct. Now, based on the presence or the absence of infection, you could either have septic infarct or bland infarct. Now, septic infarct, it follows infection or infections accompany infarction. That is, um, before the infarct occurred, there is a preceding infection, right? So it's resulting in tissue necrosis with superimposed inflammation. It occurs when emboli carrying microorganism blocks a vessel. Now, for bland infarct, it's a simple infarct without infection or inflammation. So a simple infarct without infection or inflammation is a bland infarct. Now, for red infarct, it occurs in venous occlusion, such as ovarian or testicular torsion, loose spongy tissue, such as the lung, tissue with dual circulation, such as the liver, lung, or intestine, vessel tissue previously congested. It occurs it occurs when there is re-establishment of blood flow in tissues with arterial occlusion or necrosis. Affected tissue is either red or hemorrhagic. Now, for white infarct, it occurs in the following: arterial occlusion, solid organs with end arterial circulation, like the heart, the spleen, or the kidney. Tissue density limits the seepage of blood from capillary beds. Now, the affected tissue is white, pale, or anemic. Now, the morphology for gross, that is looking at the tissue holistically, is usually wedged shape. Fresh infarcts are poorly defined and slightly hemorrhagic, but over a few days, the margins become well defined by a narrow rim of congestion. Extravasated blood are phagocytized by macrophages. This MCQS means macrophages, which converts heme iron to hemosiderin. Extensive hemorrhage leads to a firm brown hemosiderin-rich residuum. Now, the microscopic features of infarction is divided into four stages: the early stage, intermediate stage, late stage, as well as the healing and scarring. Now, the early stage, which occurs within the first 24 hours, is characterized by coagulative necrosis in most tissue except the brain. The tissue architecture is preserved, but the cell lose their nuclei. For the intermediate stage, which occurs within the first 3 days, there is infiltration by neutrophil, causing acute inflammation. There's also tissue edema, which is due to vascular leakage. Now, the late stage, which occurs between the third and the seventh day, macrophages replace neutrophils, That's the neutrophils that infiltrate the tissue, right, are replaced by macrophages, clearing the debris. There's formation of granulation tissue. Formation of granulation tissue begins at the edge of the infarct. Now, the fourth stage, which is healing and scarring, it occurs within weeks to months. Fibroblasts lay down collagen, leading to scar formation. In some tissue, e.g., myocardium, functional recovery is limited due to non-regenerative capacity of a tissue. Now, special consideration: brain infarction leads to liquefaction, necrosis, rather than coagulative necrosis. That is, in the brain tissue, in place of coagulative necrosis, liquefactive necrosis takes place there, right? Resulting in the formation of fluid-filled cavity. In myocardial infarction, that's in heart attack, it shows coagulative necrosis with fibrotic scar tissues replacing dead cardiac myocytes. In intestinal infarction, often hemorrhagic due to um, dual blood supply, can lead to septic complications. And so this splenic infarction, you could see the infarcted area here. Testicular torsion, you see congestion, obvious congestion, right? You see congestion because of the single efferent vessel. So when there's venous thrombosis, there will be congestion of blood. We have a video where we discuss about congestion and hyperemia. You can go back to the playlist and check them out. They are under hemodynamic disorders. Ovarian torsion, myocardial infarction, kidney infarct with fibrosis. Factors that influence the development of infarct. These factors include the anatomy and the nature of the vascular supply, the rate of development of occlusion, and then the presence or absence of collaterals. The anatomy and nature of the vascular supply here is talking about the blood supply to that tissue or area, right? Um, if if there's just a single afferent supply, just a single vessel that supply, more like an end artery that supply that vessel. If there's occlusion of that vessel, there's most likely an infarction is going to take place. That tissue is going to it will become ischemic and infarction will set in. So, secondly, the rate of development of occlusion and then the presence or absence of collateral. When there could, if there's a presence of uh, if there's a presence of collateral supply, the rate of infarction will be less. If there's total absence of collateral supply, then you know that the rate of infarction will be more, right? Or if there's presence, there may not even be infarction because the collateral supply may be sufficient, right, to restore, to perfuse the tissue to prevent infection. Now, vulnerability to hypoxia. There are certain tissue that are more vulnerable to hypoxia, for instance, the brain, right? Now, oxygen content of the blood. If the blood is hypoxic, if the if the blood if the oxygen content of the blood is low, the rate of infection increases. Thank you for listening. Please kindly subscribe and share if you love this content. I know you do. Thank you.